The jugular venous pressure is the indirectly observed pressure over the venous system via visualization of the internal jugular vein. It can be useful in the differentiation of different forms of heart and lung disease. Classically, 3 upward deflections and 2 downward deflections have been described. The upward deflections are the A, C, and V equals atrial venous filling. The downward deflections of the wave are the X, and the Y descent. Method: visualization. The patient is positioned under 45 degree, and the filling level of the jugular vein determined. Visualize the internal jugular vein when looking for the pulsation. In healthy people, the filling level of the jugular vein should be less than 3 cm vertical height above the sternal angle. A pen light can aid in discerning the jugular filling level by providing tangential light. The Jvp is easiest to observe if one looks along the surface of the sternocleidomastoid muscle, as it is easier to appreciate the movement relative to the neck when looking from the side. Like judging the movement of an automobile from a distance, it is easier to see the movement of an automobile when it is crossing one's path at 90 degrees, as opposed to coming toward one. Pulses in the Jvp are rather hard to observe, but trained cardiologists do try to discern these as signs of the state of the right atrium. Differentiation from the carotid pulse. The Jvp in carotid pulse can be differentiated several ways. Multiphasic, the Jvp beats twice in the cardiac cycle. In other words, there are 2 waves in the Jvp for each contraction-relaxation cycle by the heart. The first beat represents that atrial contraction and second beat represents venous filling of the right atrium against a closed tricuspid valve and not the commonly mistaken ventricular contraction. These waveforms may be altered by certain medical conditions. Therefore, this is not always an accurate way to differentiate the Jvp from the carotid pulse. The carotid artery only has 1 beat in the cardiac cycle. Non-palpable, the Jvp cannot be palpated. If one feels a pulse in the neck, it is generally the common carotid artery. Occludable, the Jvp can be stopped by occluding the internal jugular vein by lightly pressing against the neck. It will fill from above. Varies with head-up tilt, the Jvp varies with the angle of neck. If a person is standing, his Jvp appears to be lower on the neck. The carotid pulse's location does not vary with HUT. Varies with respiration. The Jvp usually decreases with deep inspiration. Physiologically, this is a consequence of the Franke-Euro-Starling mechanism as inspiration decreases the thoracic pressure and increases blood movement into the heart, which a healthy heart moves into the pulmonary circulation. Jvp waveform. The jugular venous pulsation has a biphasic waveform. The A wave corresponds to right atrial contraction and ends synchronously with the carotid artery pulse. The peak of the A wave demarcates the end of atrial systole. The C wave corresponds to right ventricular contraction causing the tricuspid valve to bulge towards the right atrium. The X descent follows the A wave and corresponds to atrial relaxation and rapid atrial filling due to low pressure. The X descent follows the C wave and occurs as a result of the right ventricle pulling the tricuspid valve downward during ventricular systole. The X descent can be used as a measure of right ventricle contractility. The V wave corresponds to venous filling when the tricuspid valve is closed and venous pressure increases from venous return. This occurs during and following the carotid pulse. The Y descent corresponds to the rapid emptying of the atrium into the ventricle following the opening of the tricuspid valve. Quantification, a classical method for quantifying the Jvp, was described by Borston Mollison in 1952. It has since been modified in various ways. A venous arch may be used to measure the Jvp more accurately. Moodley's sign. This sign is used to determine which waveform you are viewing. Feel the radial pulse while simultaneously watching the Jvp. The waveform that is seen immediately after the arterial pulsation is felt is the V wave of the Jvp. Abdominal test. The term hepatojugular reflux was previously used as it was thought that compression of the liver resulted in reflux of blood out the hepatic sinusoids into the great veins, thereby elevating right atrial pressure and visualized as jugular venous distension. The exact physiologic mechanism of jugular venous distension with a positive test is much more complex, and the commonly accepted term is now abdominal test. In a prospective randomized study involving 86 patients who underwent right and left cardiac catheterization, the abdominal test was shown to correlate best with the pulmonary arterial wedge pressure. Furthermore, patients with a positive response had lower left ventricular ejection fractions and stroke volumes, higher left ventricular filling pressure, higher mean pulmonary arterial, and higher right atrial pressures. The abdominal test, when done in a standardized fashion, correlates best with the pulmonary arterial wedge pressure, and therefore, is probably a reflection of an increased central blood volume. In the absence of isolated right ventricular failure, seen in some patients with right ventricular infarction, a positive abdominal test suggests a pulmonary artery wedge pressure of 15 mmHg or greater. Interpretation: certain waveform abnormalities, include cannoner waves, or increased amplitude A waves, are associated with AV dissociation, when the atrium is contracting against a closed tricuspid valve, or even in ventricular tachycardia. Another abnormality, CV waves, can be a sign of tricuspid regurgitation. The absence of A waves may be seen in atrial fibrillation. An elevated Jvp is the classic sign of venous hypertension. Jvp elevation can be visualized as jugular venous distension, whereby the Jvp is visualized at a level of the neck that is higher than normal. The paradoxical increase of the Jvp with inspiration is referred to as the Kussmaul sign, and indicates impaired filling of the right ventricle. The differential diagnosis of Kussmaul sign includes constrictive pericarditis, restrictive cardiomyopathy, pericardial effusion, and severe right-sided heart failure. Raised Jvp, normal waveform, bradycardia, fluid overload, heart failure. Raised Jvp, absent pulsation, superior vena cava syndrome. Large A wave, tricuspid stenosis, right heart failure, pulmonary hypertension. Cannon A wave, atrial flutter, premature atrial rhythm, third-degree heart block, ventricular ectopics, ventricular tachycardia. Absent A wave, atrial fibrillation. Large V wave, tricuspid regurgitation. Slow Y descent, tricuspid stenosis, cardiac tamponade. Prominent and deep Y descent, constrictive pericarditis. Paradoxical Jvp, pericardial effusion, constrictive pericarditis, pericardial tamponade. An important use of the jugular venous pressure is to assess the central venous pressure in the absence of invasive measurements. A 1996 systematic review concluded that a high jugular venous pressure makes a high central venous pressure more likely, but does not significantly help confirm a low central venous pressure. The study also found that agreement between doctors on the jugular venous pressure can be poor. References. External links: clinical examination page on Jvp, normal jugular vein waves, Merck Manual, JVD bedside workup,